Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. I am Kurt Barwis, your host, and I am the president and CEO of Bristol Health. Today, we have a very exciting guest. We have Dr. Robert Black, who is a hematologist oncologist at our cancer center. Dr. Black, welcome to the show. How are you doing today?
Really good. Thank you for having me.
We're excited to have you. So tell us a little bit about yourself, your background.
Well, I did my medical training at Brown University, very academic center for my residency and fellowship. But at the conclusion of that, I wanted to get away from academia and work in a community setting. So I had lived in New England for a while. I looked around and I landed on Bristol Hospital as a possible choice, came in for an interview, and I found the community setting I was looking for, small cancer center and real boots on the ground. That's how I landed here.
So what attracted you to be an oncologist? I mean, what was it that made, because you obviously going through medical school, you can make lots of choices.
I actually had a very early introduction to it. Before I got into medical school, when I was working on my application and letters of recommendation, I took a job at UPMC Shadyside. UPMC is massive beyond any comprehension, and it has a lot of hospitals. Shadyside is one of the hospitals closer to Bristol Hospital in size, and I got a job in the lab working as a hematology tech. I started reading blood smears just as a regular job that anyone would order. Doctors were ordering these tests and I was doing them for them. And at the time that was a very entry-level position. And I remember really clearly, one time I was set on the regular labs ordered by community physicians, not in the hospital, but community physicians. Came across a blood smear and it was leukemia. And even in my early phase, it was so easy to see. It was such a layup diagnosis that even I in my position knew it must be wrong. That's definitely leukemia. And so I had to flag that and call my supervisor. I found out once I was actually looking at the case I was looking at that it was a 16-year-old girl. Because of the nature of how the regulations work, I had to call the doctor because I was the one that read the smear. So I called the primary pediatrician. This was a screening blood test for sports clearance. And she was in the children's hospital of UPMC the next day. I was told that, I was able to get a follow-up on that. That was a real moment where I was already interested in being a doctor. I knew I was going to go to med school. I was working on that really hard. This job was taken. I took that job to better my resume to that effect. Yeah. But that's when blood and cancer really came into, well, it's like a very impactful choice for what I could do. I could help a lot.
That's an amazing story. I mean, it really, and I could see how that would motivate you. And I never heard you tell that story before. So
I don't tell it a lot, but it is the first time.
Just digesting that because it explains a lot. I mean, why you're so passionate about what you do.
So once I got into medical school, I was interested in hematology, blood, and oncology. And I wasn't even clear exactly how tightly connected they were at the time, but they're very tightly connected. And that's very early in the process, that is an area where you have to do it off of fellowship, off of internal medicine. So it's a real long goal. It's getting into surgery is actually a more simple process than that. So there were a lot of steps that needed to happen for me to reach that goal. So I did explore other fields while I was going through it, but I kept coming back.
So it's interesting you just mentioned hematology and the connection in the blood, to cancer. So talk a little bit about that, because I'm always curious about, so oncologist, hematology, oncology go together. So why is that?
A lot of it's for historical reasons, and there are some times where it overlaps and some times where it does not. But these days, cancer management has gotten so complex that there are many programs certifying fellowship-trained physicians for medical oncology only, and they are not doing the hematology component. That, though, is not as applicable to a community setting, and I really wanted to stay in the community setting. So my goal was to get double boarded in hematology and oncology because there's a need for both of those. Why they are tied so close, though? It has to do that a lot of cancer treatments, even if they are not blood-based, even if the cancer itself is not blood-based or the treatment is not, impacts the blood very heavily. So my treatments greatly affect the blood, and I need to be able to understand those blood changes to safely negotiate those treatments. So that's the main connection.
Wow. So talk a little bit about the Cancer Center at Bristol and the range of cancers that you treat there.
Well, we see very many cancers. It's actually it's a shorter list to say the cancers we do not treat. And there are some very esoteric and rare cancers, such as sarcomas, brain cancer. These are some cancers that we are just not equipped to deal with at Bristol Hospital, not because I can't, but because it requires support staff in terms of other physicians that I don't have immediate access to. And these days, cancer management is multidisciplinary. You don't just have an oncologist. I'm just one member of a team, and I need all those other members. If I don't have them, I can't effectively treat that cancer. So what we do see is a lot of the common and real impactful cancers in terms of America at large: lung cancer, colon cancer, breast cancer, prostate cancer. And even with those four, you have a vast majority of the cancer in America. And then, of course, there's others as well. We see esophageal and gastric. We see rectal. I see any kind of lymphoma. And we do see leukemias, depending on the type. Now, there are some times where we need to defer to some higher level centers that have bone marrow transplant available. And that's something that we don't do at Bristol Hospital, but I have a good working relationship with the transplant center at Yale New Haven Hospital. And so we're able to manage those patients as well while referring them for those treatments. We also see other types of benign tumors, actually. They're not necessarily cancerous, but there are some benign gastric tumors. There are some benign lung tumors. Carcinoids are things that people have. It's not quite cancer, not quite benign. There's a lot of overlap there.
So the range is extensive, and the really cool thing about it is you could stay within the community that you live.
I like
and
that,
get a really amazing care. And I guess one of the things that's kind of startled me, and the more that I've been in this field, is that the treatment protocols, you have to follow those proven treatment protocols that are established. So when people ask me about, where should I go? And I say to them, well, if it depends on what your cancer is, but pretty much is it the NCCN guidelines, the National Cancer Institute guidelines?
That's the most prominent one. There actually are about 4 others I could think of that I do utilize, but NCCN is the most prominent guideline for treatment pathways. It's very specific to the treatment pathways, but yes, that's the one we utilize the most. And I often will reference that the treatment pathway, in terms of which treatments to do and when and in what order, much of that is laid out because of evidence-based medicine. And evidence-based medicine is the type of medicine where you are utilizing statistics and large clinical trials, double-blinded clinical trials, so that there is no bias in the interpretation of the effect that the treatment has on the cancer. And then once you have that data, standardizing it so that any physician can follow that. And this is very important to me in my position at Bristol Hospital, because it allows me to give my patients the same quality of care that they would get if they traveled down to Johns Hopkins or the Cleveland Clinic. These are national guidelines. It's what they're doing, I can do. And if you follow the pathway in a very exacting way, you can assure your patients that they're getting the highest quality care because it's written down. It's right there in the trials.
You make me feel good, because I get that question all the time from people, like, should I go here, should I go there? And my answer is usually exactly the same. I say, so the care should be exactly the same. What matters is how you feel when you walk in the door. Does it make you feel comfortable? Does it exude confidence in you? Do you like your care team, your oncologist, the rest of the team that you're working with? Do you like the people that you interact with? You know, that's like what makes all the difference in the world, because, you know, often patients are coming frequently for treatment, closeness, proximity, all that. We had, I remember when we first opened the cancer center, there was a very well-known individual in the healthcare arena who had a very aggressive cancer, and he went to Memorial Sloan, he went up to Dana-Farber, and he ultimately chose Bristol Health. And he wrote a blog about, I'm actually getting my treatments, my chemo, from a nurse that I went to high school with. And what matters to me, because I know that there's really not any difference, is that I'm in my own community. I live literally right around the corner from the hospital. And, you know, and as an administrator, I was like, because I was friends with their wife, an executive and all this stuff. I was like, wow, this is really powerful. So I think everything you just said kind of reinforces all of that, right? I mean, I don't think I'm wrong in saying what I say. And I've seen it over and over again. And so Bristol is a great option if you want to have that kind of a engagement with a community hospital, which is why you picked a community hospital to begin with, right?
I think that the personal approach is something that we can offer that perhaps larger centers can't offer. Now, there are absolutely times where the standard of care and the treatment plan for a particular cancer is so complex that I cannot safely negotiate it with the resources that I have. But I would argue that those times are much more rare than you think they were. And I would be upfront immediately about whether or not I felt comfortable taking on a case. And certainly this is after the initial visits where we're establishing the actual diagnosis and the stage of the disease. All of that can be done at any hospital system because you're pre-treatment. You're assessing the severity of the condition. You're getting the good or bad news. And that's before you reach the complexity of the care. And all of that can absolutely be done at any place, certainly Bristol Hospital, even if we ultimately decide that the care needs to be at another institution for the sake of complexity or safety. But this is absolutely right. I think there's a real benefit to having care close by. It feels local. And it's absolutely true that cancer treatments can be very frequent and travel can be a real barrier. I need my patients in the clinic a lot, and they have to come back, draw a lot of driving time. And so proximity is a major factor sometimes.
Yeah. So what do you see? I mean, it feels like in just the time I've been in Bristol, there's been so many advancements in the treatment of cancer. I mean, we now have pills and things people could take at home, and you know, where are we going? I mean,
Well,
I'm just
mean,
curious.
a fun fact, at least a fun anecdote. 30% of my board certification for medical oncology is rote pharmacology, straight pharmacology, just drugs, their names, their interactions, and how they're administered. And that's not regarding any kind of diagnosis or what they're used for.
Yeah.
And so that goes to your point of there's a new treatment, there's a new drug seemingly every day. That is actually one of the most challenging aspects of my role. Since I see many different types of cancer, I can't focus my learning on just one subgroup of cancer. And that does pose a challenge for keeping up to date. But the guidelines that I talked about and the national meetings that I go to, the meetings, ASCO annual meeting, Best of ASCO update meetings. This is how I utilize the resources available for America's doctors at large and get what I need to stay up to date.
Yeah.
We get a lot of updates via email. It's a very simple way to do it, but it's very effective when you hear that there's a new trial out and the major publications that have those trials, like the New England Journal of Medicine. If that's got a major update, I get that update, incorporate that into our workup. And so the guidelines do as well. So when you're reviewing the guidelines, you'll notice the change.
Yeah. So somebody that's newly diagnosed with cancer, and if they choose any hospital, there's a thing called a tumor board, right?
That's right.
So how does that work? Because I think people get confused by that.
I wonder if it's actually a required thing. I wonder who would require it, but I have to say, I cannot imagine a cancer center at any institution not having a tumor board. It is absolutely standard of care to have a multidisciplinary tumor board. At these tumor boards is a medical oncologist, such as myself, or any amount of them that you have in your group. Almost always the entire practice will show up to this. You'll have a medical oncologist, you'll have radiation oncology, radiation, another field very important to cancer treatment. You'll have a surgeon. If the case involves surgery, often they'll show up for their own cases. This could be general surgery, colorectal, thoracic. You'll have pathology. They'll need to be there to discuss the actual pathologic diagnosis and the biopsies. You'll have a radiologist. They're there to discuss the imaging studies and clarify stage and where the tumor is seen on the CAT scans. And then we'll also have some ancillary staff there as well, such as our nurse navigator, because it's very important for them to know where the workup and the treatment is going to go, because they're instrumental in coordinating that, as well as social work. But the tumor board is meant to gather all of the practices, the different areas of medicine that are relevant to creating a cancer treatment plan in one room, or whatever online meeting that you're doing, in the same unit, so that you can discuss a singular case completely and make sure everyone's on the same page. And every cancer center does that.
Yeah, I've sat through some of those tumor boards, and it's really amazing to see that it is a team. And I don't know that necessarily, people interact with the pathologist or directly with the radiologist or some of those people behind the scenes, but the value that they add as they go through it, and from my perspective, it's almost like a double check on the direction that is being taken, that it actually does meet those guidelines. And I've been through some of the credentialing for some of these programs, and when the surveyors come in, they want to see that you've actually done this and you've compared it and it matches the guidelines very carefully. So it's really quite extraordinary. So in the environment, I know you're very busy because I see the volumes. It's a very busy center. Where, as you kind of look forward to the future, where do you see the cancer program at Bristol going? What do you see the next logical kind of steps for us?
Well, that's an interesting question. I think there's a lot of different ways you can go with it. One of the things that I'm always hopeful for is being able to formally integrate radiation oncology into the cancer center, either closely in the same building or perhaps logistically closer so that I can work directly with the radiation oncologist. We already work very closely with them. I can't tell you how many times we text each other through our secure texting app to discuss patients and make sure that the care is coordinating. There are times where they need to be doing a treatment at exactly the same time that I need to be doing a treatment, and it's got to be set up that way. So that kind of communication is critical. And having a comprehensive cancer center where you've got both groups, both specialties right next to each other can be very helpful. Another area that I'm hoping to bring together in a similar way is pharmacy. We deal with a lot of drugs. We have a lot of drugs, and the drugs that we use are complex. They're infusional. They require mixing. They have time attached to them, like lifetime. They don't last very long. They need to be in a certain temperature. They need to be given a certain way. And many centers integrate an actual pharmacy within the cancer center itself so that they can be mixed on site. That's another area that I think is worth exploring. These are the things that I have in my mind, but there's so many ways to improve the care.
So Dr. Black, your first one of combining rad-onc and medical oncology to me has been a goal for me since the day I walked in the door there, because I see that when I talk to patients, newly diagnosed where there's potential for rad-onc being involved. And it doesn't matter where you go. It's, could be a large center and you're still going to a different part of the building, and having it all together just, makes so much sense. So I'm going to try my best to make some of those things happen for you. The space limitations in
those
the
are
center.
Complex asks. So I'm not just pitching that.
No, but they're very important, and I think patients in general benefit from knowing that there's that team includes, because it used to be very linear, right? So med-onc then rad-onc, but now, as you described, you can have both things happening at exactly the same time. Chemotherapy and radiation oncology can happen simultaneously based on the clinical guidelines for treating a cancer, whereas before you did this and then you went on to this, or at least it seemed that way to me. So, so Dr. Black, this has been a very educational program for me, especially. Anything you wanted to impart to the viewing audience about cancer, about our program, anything at all?
Well, we are there for you. We will see any individual, and no matter how complex the case, I can guide you through the diagnosis. We will help you any way we can. And if we can keep your care at Bristol Hospital, we will. We'll endeavor to do so. If we need to engage other services, you can trust that we will bring you the highest quality of care.
Thank you. That is awesome. Really, I really appreciate you being here today. Maybe we'll do another one, because I think we could probably spend quite a few more. So this is Bristol Health Cares, and you can write us at cares@bristolhospital.org with any suggestions if you who you'd like to have on the program, and we'll try our best to do that. We're here in the Nutmeg studios in Farmington, and Nutmeg TV is a nonprofit organization. It's an award-winning nonprofit station, and it deserves your support. So if you're watching this program, I encourage you to to pick up the phone and support this nonprofit organization, because we want to really be able to keep doing this for a long, long time. So so thank you again for joining us today. And this is Kurt Barwis, Bristol Health Cares, signing off until the next time.